Hi, it's 6:30. We are live. Dr. Ng, would you like to turn on your video? Hi, Dr.
Hello.
Ng.
Hi, can
So
you hear me?
it's 6:30. Yep, I can hear you clear. Can you hear me?
Yes.
Okay, that's good. So anyway, it's 6:30 p.m. and we are live. A very good evening to our fellow audiences in Zoom and Facebook Live. Happy, what day is today? Happy Wednesday. And I'm Hazel from Dr. X Dentist, and you are very welcome to today's session titled Consult a Surgeon for Colorectal Cancer. So I'm very excited to be joined by our panelists for today, Dr. Ng Chi Yang. Hello, Dr. Ng. So before I properly introduce Dr. Ng, I'm just going to quickly run through some general housekeeping. So first off, we are recording today's webinar and it will be available on our Facebook page, Dr. X Dentist, for you to revisit after the webinar. But if you're lazy to search it out, it's okay. You can stay tuned for our post-webinar email, which is usually sent out the next day, so tomorrow. And we will send you the link to the recording where you can view it. So secondly, we will be having a live Q&A with Dr. Ng towards the end of the webinar. So throughout our conversation, please feel free to use the Q&A function in Zoom. And for our Facebook Live audience, you can put your questions in the comment box down below. And we do hope that we'll have time to get to all of the questions, but it's very hard to judge in advance. So if there's any questions we didn't manage to get to, you can always drop your questions at our website, www.drxdentist.com. So that's all for housekeeping. Let's properly meet our panelists. I'm happy to introduce to you Dr. Ng Chi Yang. So Dr. Ng is a colorectal surgeon with one surgical clinic and surgery. He served as a senior consultant surgeon of Singapore General Hospital and was also the director of the Center for Digestive and Liver Diseases. Dr. Ng is also currently the president of the Society of Colorectal Surgeons Singapore, SCRS. And Dr. Ng, would you like to kick things off by giving us a little bit of background of yourself and the work you do?
Right. Thank you, Hazel, for your kind introduction. It's an honor to be on this webinar, but I'm a bit of a newbie as webinars are concerned. But I think, well, I hope this is not a new normal for us, but this is the first kind of a public webinar I am doing. Well, maybe to start off, just I mean, Hazel did mention I'm a colorectal surgeon. I'm in private practice at the moment. And just to explain what a colorectal surgeon is to some who don't know, basically I'm a gastrointestinal doctor and that specializes in treating diseases of the colon, rectum, and anus. And many of the conditions that affect the colon, rectum, and anus require some form of a surgery to treat, and therefore I have to be trained as a surgeon. But apart from surgery, I also perform gastroscopy and colonoscopy, or what you might term as scopes. And that is a very important non-surgical procedure that is used to diagnose and treat many gastrointestinal conditions. I graduated in medicine 23 years ago. And as Hazel mentioned, I used to work in Singapore General Hospital before I left for private practice in 2016. And as she did also mention, I'm honored to serve as the current president of the Society of Colorectal Surgeons Singapore. In Singapore, we have about currently 80 odd colorectal surgeons. The society is a professional society that all colorectal surgeons are part of, and it aims to further the practice of colorectal surgery in Singapore. I guess that's about all I should say, and not take up too much time.
Okay, thank you, Dr. Ng. That was a good introduction. So Dr. Ng has kindly prepared a presentation on colorectal cancer for us. But before we really delve into the details, perhaps Dr. Ng, we can start easy and briefly introduce the topic to our audience. So firstly, the big question is, what is colorectal cancer?
Well, maybe I'll break that question down a little. Now, cancer is actually, you term it as a group of diseases characterized by the development of abnormal cells that divide uncontrollably. So it would form uncontrollable growth. And these cells have the ability to infiltrate and destroy normal body tissue. So that's the hallmark of cancer. So colorectal cancer therefore refers to cancer that evolves from the colon or the rectum. Does that make sense?
Yes. Okay. So are colorectal cancer, colon cancer, and rectal cancer, are they all the same?
Okay, I think colorectal cancer
Mm.
refers to cancer of the large intestine, which you
Mm.
may understand it as. Now, the large intestine itself is actually subdivided,
Mm.
or I mean, this is terminology, but we would say that uh, the end part of the large intestine, which is just above the anus, that's the
Mm.
rectum. But the most of
Ah.
the whole length of the large intestine is the colon.
Oh, okay,
Okay.
okay.
Yeah. So the colon refers to, say, the first 80% bit of the
Mm.
large intestine, and the
Mm.
rectum is about, say, the end bit, which is about 20%.
So colon cancer and rectal cancer is a subset of colorectal cancer.
Correct.
Okay,
Correct. Yes.
good conclusion. Okay, so my next question is how common is colorectal cancer? Is there a specific demographic of people who are more susceptible to colorectal cancer?
Well, actually, colorectal cancer, unfortunately, is the commonest cancer
Mm.
diagnosed in Singapore. It is the third most common cancer in the world, but in Singapore, it is number one.
Wow.
And there are many postulates why it is number one in Singapore, but we have observed that in urban environment compared to rural environments, the colorectal cancer rate is much higher. So I guess because Singapore is a city state, we don't really have much rural, environments here. So I think our colorectal cancer rate is very high. I probably will talk a little bit more about what is unique or what is bad about the urban environment that gives the cancer rates that are high. But I'll talk a little bit more about statistics first. In Singapore, about 2,000 cases are diagnosed, and every year, unfortunately, there are 1,000 deaths from colorectal cancer
So that's about
in
half.
Singapore. Yes.
Hmm. Wow.
And it is so common that actually, statistically in Singapore, almost about 1 in 20 people
Hmm.
you meet on the street,
Hmm.
at some point they will get colorectal cancer.
Oh my God.
So that is really how common it is. It's around
I'm
1
shocked.
in 20
Uh,
or 5%. That's pretty high.
yes.
Uh, yeah, and it's a bit sobering when you put the numbers in those terms.
Hmm.
And as for demographics, it tends now it is quite strongly age related in the sense that approximately 80% of cases
Hmm.
would occur to people over the age of 55.
Hmm.
But it also means that 20% will be younger than 55. So being relatively young does not necessarily protect you. There's
Hmm.
still a chance, but most
Hmm.
cases are 55 and above. And in terms of racial distribution, interestingly, the Chinese population
Hmm.
is ahead of the Malay,
Wow.
and they are ahead of the Indians.
Hmm.
It is not clearly understood why,
Why?
yes, but the Chinese population are more at
Hmm.
risk.
Hmm.
Um, yeah,
Are there speculations to why? Like diet,
yeah,
genetic?
I think no one really has accurate idea, but
Hmm.
you might speculate that partly is the diet,
Hmm.
as you say, but I'm sure partly is also genetics.
Hmm. Definitely.
Yeah.
Okay. I think that's a good kind of you kind of nicely set the scene for the statistics. And I think we have a good foundation for this. So Dr. Ng, you can start your presentation now and you want to share your screen maybe.
Yeah. Okay.
And while Dr. Ng is sharing his screen, our Zoom and Facebook Live attendees, once again, please feel free to leave your questions in the Q&A platform in Zoom and comment box in the Facebook Live. at any point during Dr. Ng's presentation. So, okay, I can see it. So
Can you
Dr.
see?
Ng, the
Yeah.
stage is yours. You can start
Right.
now.
Thank you. Right. So today I'll just give a short presentation on the types of treatments that we do nowadays for colorectal cancer. Try to. Okay. Now, broadly speaking, the concepts in treatment of colorectal cancer would be, simplistically, you could think we want to physically remove the cancer, and we might be able to do that with a form of surgery, or sometimes we can do it through endoscopy or scope. Or we might think, is it possible to poison the cancer? Now, conceptually, chemotherapy and radiotherapy are cancer treatments that poison, so to speak, the cancer, that poison it in a way that it either stops growing or hopefully starts to die off. So broadly, these are the two concepts in treatment. Now, which way is best? Actually, there is no one best treatment that I would say applies to every case. Treatments should always be individualized, and there are certain factors that will guide us what we might recommend. The important things to think about is that when the person is diagnosed with cancer, is it early or is it late? Because the options are different. And what is the current physical health of the patient? Because certain treatments, you need to have a certain like minimum fitness to actually undergo. So it's also important to know what are the patient's other medical conditions that they may have. And putting it all together, we then decide what might be the best treatment for that particular case. So simplistically, I will broadly divide treatments based on whether we are talking about an early stage, mid stage, or a late stage cancer. I think you can see my pointer. This basically shows how we might stage cancer, and most people will know that most cancers are staged between 1 to 4, and in increasing order of it being advanced. So, say if we have an early stage cancer, which means that it is the growth is still confined to the intestine or the intestinal wall. And in that situation, removing the cancer physically would make the most sense, because this cancer has not spread beyond that point. And if we could do a procedure that can cleanly and completely remove it, then we will have a quite will be quite confident that we have dealt with the problem adequately, right? And in this setting, in say stage 1 and 2 cancers, the cure rates are as high as 90 to 97%. And on the right, I'm just showing roughly, what I do for most of the cancer, the surgeries. Essentially, you can look at it as a little bit of a plumbing job, because we have to remove a section, for example, here, and then we have to join the rest up. And of course, depending on which section we have to remove, the operation is a little bit different, but the concept is generally the same. We want to remove a small section that includes the cancer, and then we want to make a joint so that that person will be able to go about his business in the normal way. So that's the concept. Now I'll move on to talk about what if the cancer is what we call in the middle stage. So in this stage, especially say if you look at stage 3, it's a cancer that has spread to the surrounding lymph nodes. So it's not just confined to the intestinal wall, it's gone to the lymph nodes. And in this type of situation, the removal or the physical removal of a tumor is still important, but we have to get more, ammunition, or we have to use, chemotherapy and sometimes radiotherapy in addition to physical removal, to reduce the risk of recurrence. Because in this setting, the cure rates, unfortunately, are not as good, and we're talking about in the range of 50 to 70%. Okay, and then moving on to say the unfortunate cases that come quite advanced in stage 4, which means that the cancer has spread to the other organs. In this setting, actually chemotherapy is the mainstay of the treatment, because since the cancer has spread widely, we want a treatment that can target the entire body, which is chemotherapy. And physical removal of the tumor is less important, but it is sometimes still necessary. If, say, for example, if the tumor grows to a certain size that it might cause a complete blockage of the passage of the intestine, let's say here it grows bigger, then we are going to have to deal with that because you can't live with a blocked intestine. So we need a kind of a physical treatment to deal with that. But the mainstay of treatment in this stage is actually chemotherapy. Now, actually, chemotherapy has improved dramatically in the last 10, 15 years. And in colorectal cancer, even in stage 4, there are many patients who live several years. And in fact, sometimes when you meet them, you can't even tell that they are cancer patients undergoing chemotherapy. Now, I'm going to focus. I'm a surgeon, so I'm going to focus on what are the methods of tumor removal or physical, removals. Broadly speaking, I've divided them into 4 types of procedures. There is the scope procedure, or called colonoscopy. Sometimes we can do something called transanal surgery, which I'll explain in a minute. And a lot of people would have heard of a keyhole surgery for surgery to the abdominal organs, of which, of course, the colon and rectum is. And of course, the traditional way is open kind of operation. Now, okay, colonoscopy is actually the usual way that one might have been diagnosed with the cancer. Okay, now sometimes we are fortunate in that the cancer is quite small and quite early, and during the colonoscopy, we can do a fairly simple procedure to actually kind of cut it off. And now, a lot of the times that we have made the cancer diagnosis, it is actually not in such a favorable early state. But we do have cases where the cancer might be, for example, if you look at this polyp, maybe only part of the polyp, let's say a small area, was cancerous. And if we were to cut this off during the colonoscopy, we would have cured this person of the cancer. Now, I spoke about transanal surgery just now. Now, what is it now? Sometimes in cancers that might develop quite close to the anal region, and if the cancer is still fairly small, usually applies to stage 1 cancers, we can actually put a device with fine instruments like this, and that kind of goes in like this, and we can actually remove part of the intestinal wall, and we can even repair it and stitch it up um, from this. So this type of an operation would have no physical external cut or wound because everything is done from the anus. And if you are fortunate, or I mean, if the cancer is early, then this might be a applicable method. And this type of operation is very good because this patient typically can go home on the following day. Very quick recovery. Now, a lot of people would have heard by now of keyhole surgery. This is a method where we insert very fine instruments like this through small incisions, where what they call the keyholes, and we can uh, manipulate the abdominal organs, and we can do our operation through the tiny cuts. Typically, relatively quick recovery too, and you might stay about four days in hospital. And in fact, nowadays the majority of cancer cases can be treated this way, and there is no big cut on the belly. This is one of my patients where I had performed a keyhole operation on for cancer. And you can see the small scars from the operation at 2 weeks. And I followed her up at 2 years. This is what her belly looks like. You can hardly see anything now. I want to talk a little bit about an advanced version of keyhole surgery, and that is with the use of the surgical robot. So in this type of an operation, this is the robot, and in fact, the robotic arms are handling the keyhole instruments here. So it goes into the uh, the patient's body here, and the surgeon, that's me, will sit on this kind of a machine, or what we call as a console, and there's a controller there, looks like this. I would insert my fingers in, and by manipulating the controls here, the instruments inside move. And this is the viewer that I get, and you can see that it's got a left eye and a right eye. So I will be able to have a 3D vision, which helps in fine movements. So what is the difference of this type of keyhole surgery is that if you look at the robotic instrument, it looks like a miniature hand because it can curve in many directions, and it is measured as more movement than the human wrist. But if you look at the keyhole non-robotic instrument, it just kind of looks like variations of a scissor. It only has one hinge, and so you can't. It's much more difficult to do fine work. But realistically, most cases, we don't actually need to use the expensive surgical robot. And really, it is more relevant to this type of operation where we have to work on a cancer that is near the anus. See, we are trying to avoid having to lose the anus entirely in this kind of an operation, because if you lose the anus completely, this person would have to have a permanent, what we call a colostomy, and would not be able to pass motion in the usual way. But the surgical robot has allowed us to do very difficult operations near the anus. I might skip a few slides, but suffice to say that in surgeries of the rectum, which means it's near the anus, uh, the level of difficulty is much increased, and hence the surgical robot is very useful. And we are always trying to preserve the anal muscle, and yet we still need to aim to the the clear the body of the tumor itself. For example, these are some of my actual cases. These are actually MRI scans where you can see that in this particular case, this cancer was right on top of his anus. And in this case, there are many similar cases close to the anus, but with the robot, we can do this kind of an operation where we can still reconstruct everything. Now, moving on to the most, I would say, traditional way of doing is to make a big cut where we, operate with our own eyes and with our own hands, and it's a traditional method. We still have to do it sometimes. Not every case is suitable for a keyhole operation. Sometimes the patient might have had multiple surgeries in the past that might make a keyhole operation very difficult, to do. Sometimes the tumor itself has grown in a certain way that makes it very complicated to do the surgery if you were to do by keyhole or even with the robot. And unfortunately, if you do an open surgery, the hospital stay is a little longer. So my last slide, I just conclude that as of now, presently, surgical removal is still the mainstay of colorectal cancer treatment, which kind of means I still have a job. The vast majority of cases can be treated with keyhole surgery with small wounds and very fast recovery. But the bottom line is that colorectal cancer is curable, especially in the early stages. Treatment advances have improved the cure rates as well as the quality of life of cancer survivors. At the end of the day, though, prevention is still better than cure. And we can talk a little bit about this, but I would advise everyone that is concerned, please see your doctor about colorectal cancer screening. So that's the end of my presentation.
Thank you, Dr. Ng. I think we can stop. Oh, nice.
Yep.
So thank you for the presentation. I'm going to jump straight into Q&A now. So for our audience, if you have any questions or doubts with regards to Dr. Ng's presentation, now is the perfect time for you to put your questions in Zoom. It's the Q&A platform, and for our Facebook Live, it's in the comment section down below. So we actually already have a question on Zoom, and this is it's an anonymous attendee, and the person states his case. So he's a male patient. He's 57 years old, and the results of his colonoscopy is he has multiple polyps, 5 to 10, in the rectum. So the results of his biopsy is adenoma. Is that how I pronounce it? Adenoma. And his family history is unknown, and he wants your advice on his case.
Okay. Usually, adenomatous polyps, which is what he has, can be completely removed with the colonoscopy. So I presume that has been done. If it has not been done, he should consider doing another colonoscopy to make sure that all the polyps have been removed. Okay. Now, let's say it's been removed. Then we look at the biopsy report to see whether there's any worrying features. Okay, if the report says that it is an adenoma, we actually subclassify it a little bit. It's a bit technical, but basically adenomas mean that it is benign. It means it's non-cancerous. But we know that adenomas have a theoretical possibility of evolving in time to be cancerous. But given that it's been removed, he has avoided this potential possibility. But what's important is surveillance, because given that he had formed adenomas in his rectum, moving forward, he is at increased risk of forming other or new adenomas, right? So typically, he may be asked by his doctor to repeat his colonoscopy, perhaps depending on what the biopsy shows, sometimes they may say, come back and do another one in 3 years. If the biopsy shows a little bit more worrying features, they may say, come back and actually repeat it in 1 year. Yeah. The other thing to know is that if you have polyps, you especially may want to tell your other family members that you have polyps, because sometimes the tendency of developing polyps run in families. And so if he has siblings, or if his parents had never done a colonoscopy, it's worthwhile considering for screening.
Okay. Thank you, Dr. Ng. I hope that answers your question, anonymous attendee. If you have a follow-up question on that, feel free to leave it in the Q&A platform. So we have another question, and it's from Andrew. So it's also related to the colon polyps that you mentioned. So he asks, is it normal for most people to have colon polyps? So his dad had colon cancer in his last 30 years. He survived and is still living at 70 plus. So he has gone for colonoscopy since his mid-30s and seemed to have a few polyps removed at each screening. And he isn't aware that polyps might be considered stage 1 colon cancer. Actually, is polyps considered cancerous? No, it's considered cancer already if you have it.
Okay, actually, polyp is a generic term for like a fleshy growth that comes out from the inner lining of the intestine. And you may subdivide polyps into non-cancerous, or what we call benign, or cancerous, which are or malignant, right? But when someone use the term in a lay fashion, it usually means it is still in the benign stage. Okay, but technically speaking, you might have cancerous polyps too. Right now, so you might think of polyps as an evolving spectrum. You've got early to middle to late, where it's at high risk of transforming into cancer, right? Now, most of the time, polyps can be removed at the time of colonoscopy, unless they have grown extremely large. Then sometimes it is not safe to remove it during colonoscopy. In this person, if my math is correct, his father would have gotten colorectal cancer very young, because if you say his father's in his 70s and survived it for 30 years, which means the father got colorectal cancer at 40 something, perhaps, which is very young. And that means that he and his other siblings are actually at high risk of developing polyps and hence cancer, and he would be recommended for a more intensive surveillance program, which sounds like he's doing, which is the right thing. Yes. And if every time he's done a colonoscopy, he has found that there were polyps that needed to be removed, then it certainly was the right thing for him, Now, is it normal? I wouldn't say it's completely like normal to have like polyps, but it is quite common if you were to, the rate of you forming like polyps randomly will increase with age, So if you've reached, let's say by the age of 50, 60, I'm talking about the average person and not necessarily one that has a family history, right? So, by the age of 50, 60, if you were to do a screening colonoscopy, there may be at least 10% chance you might have a polyp, but but most likely it's still at the benign stage, right? And it can be, removed on the spot.
How common is it for the polyps to develop into a cancerous one? Is it like with time, if you leave it there, it will eventually
No,
develop?
no, I would say the vast majority of polyps will not become cancerous, right? But it is too risky to leave it alone. For example, if I'm doing a colonoscopy for a patient and I find a small little lump. Now, statistically speaking, maybe that lump only has a 1% or 2% risk that maybe within 10 years it will evolve to become, cancerous, but I can't take that risk. So any small lump I will remove, right? Not all polyps will progress to cancer, but you can't predict which will and which won't when it is small and early. Yeah.
Makes sense. Okay. Thank you, Dr. Ng. I hope that answers your question, Andrew. So we have another question from Hasmi. So she asks, has someone ever had colorectal cancer and he can get it again for the second time? I guess after the cancer cells were cured.
Yes, unfortunately, there are cases like this. I do not know if you remember my slide where I showed you, typical types of operations that we may do. Like I said, it was a bit of a plumbing job, so we will, remove one section and then we will join it back up, right, to restore continuity. So of course, you've got the rest of the large intestine there, and usually a surgeon tries to keep or save as much as it is safe to save, right, so that you can maintain the function of your intestine. And but of course, the remnant large intestine or the colon or the rectum will have a risk of developing cancer. And in fact, that person who has had the first cancer is at increased risk, given that he had developed that first cancer. There is a suspicion that there may be something that he's got the risk factors, right? So the same risk factors will also apply to the rest of the intestine that is left behind. So it is possible to get the second cancer.
So I guess
There are
for
some cases, I just move on a little bit, just touch on that. In some cases where the family history, if someone has an extremely high family history uh, of uh, of colorectal cancer, and one member newly develops a cancer, sometimes the surgeon will recommend actually removing more of the colon than what is typically required just for the treatment of that cancer, just to reduce the risk of the second cancer.
Okay, I hope that answers your question, Hasmi. Let's see. We have another question from Tae Gik Kiam. So the person asks, are there certain types of polyps that can be missed during a colonoscopy?
Yeah, very good question. Now, I would say that, no test in medicine, if you treat colonoscopy as a test, okay, because it's trying to diagnose or to detect something, no test in medicine is absolutely 100% diagnostic, okay? There is always a small missed rate. So a colonoscopy will likely, detect 99 odd percent of cancers. I mean, I mean polyps, right? But sometimes there are reasons why polyps might be missed during the colonoscopy, because the intestine, the curvature of one's intestine is quite variable from person to person. Sometimes there is an acute angle where the view of the scope view to see or to examine is not full, it's not the entire circumference, or of the intestine that you're trying to see. So it's possible to miss, or you might have a blind spot that the colonoscopist cannot see. And sometimes, say if the bowel preparation was not that clean, prior to going for colonoscopy, it's routine to consume something called bowel preparation, which means you are given something to clear the bowels and flush the system clean. So if the bowel preparation is not so good, there's still a lot of um, uh, residue. So sometimes you can't see everything. So these are the reasons why occasionally there are missed polyps, but these would not be that common.
Okay, actually, we have a question on bowel preparation. So it's again by an anonymous attendee. So the person would like to ask you, do you think we have to do bowel preparation for all patients who are going to undergo colorectal surgery, or is there any condition that we don't need to do it?
Okay, in fact, that is a slightly controversial topic, even among surgeons. In the beginning, undergoing bowel preparation before colorectal operations was routine, and conceptually maybe that made sense. You want to do an operation on an area that is as clean as possible. Okay, but later on, there was some research that showed, there's some studies that showed that actually giving the bowel preparation made very little difference to the success of the operation. Okay, so it kind of swung the other way, and it became kind of optional, at one point. Now there's a very new research that has actually swung things back in the other way fairly recently, and showed that if you give bowel preparation versus no bowel preparation, um, there may not be any difference in the success. But if you were to combine bowel preparation with special oral antibiotics, then there was a slightly better outcome or less infection rate, and that's fairly new. That's fairly new.
So I assume and I conclude that yes, it should be done, but with that, what was the thing you said?
There is an antibiotic that you consume together with the bowel preparation. But I must tell you that this is quite new research, and that it's not routinely practiced in Singapore because it's so new, and also this particular antibiotic is not widely available in Singapore yet. So this is really quite hot off the press. Okay, until fairly recently, it was thought that the bowel preparation was optional, and it was more the surgeon preference.
But if it's you, do you usually recommend yes?
Okay, if it's me, now that's a complicated question.
Okay.
If it's me, certain types of procedures, I will want to have bowel preparation. Certain types, I would say it's not required.
Okay. Do you think that the antibiotic that you mentioned will be coming to Singapore soon? Is it?
Interestingly, that particular antibiotic used to be quite widely available
In Singapore?
Yeah, around the world.
Oh,
And
wow.
it's
Okay.
fallen out of favor. And so I think no one brought it in anymore, interestingly. And do you know why? Because now this antibiotic has got a very low rate of absorption. Most antibiotics that we eat, we swallow it, and we want it to be absorbed into the bloodstream, to treat your infection. In this particular case, this antibiotic, we actually deliberately want it to remain in the intestine. We don't want it to
Oh.
be absorbed. So it had kind of fallen out of favor because it has poor absorption. It's not a very good antibiotic to treat other
Yeah.
infections. You know what I mean? So it's kind
Yeah.
of not it's not a usual choice
Uh,
of treating routine infections. But in this very unique case,
it's
we actually
useful.
want an antibiotic to remain and not be absorbed because we want it to work inside the intestine. So now, suddenly we have to kind of get a source of this old thing.
Mm.
If yeah.
That's actually quite funny. The antibiotic has found its calling, its true purpose. But okay, I hope that answers your question, anonymous attendee. So we have another question from Andrew again. So Andrew asks, assuming that the average duration between colonoscopy is 5 to 7 years, are there any leading symptoms or indicators such as piles, bloatedness that might be a trigger for a colon screening shorter than the recommended 5-year duration?
Okay, I would say that when you use the word screening, right? Technically speaking, I would say screening applies to you following a routine, interval of that checkup,
Mm,
and meaning that you should be kind of asymptomatic, meaning you have no complaints, but you are just going for the check at the predetermined time interval. But when you do have some symptoms, okay, that the recommended screening interval not necessarily, applies anymore. For example, if you had a colonoscopy, say 4 years ago or 3 years ago, and now, and you were completely well at the time, and now you felt, you've got this bloated feeling, or you've got a feeling that when you go to the toilet, you can't seem to empty completely, you can't evacuate completely. And so you have some kind of a odd symptom. And then if you were to go for a colonoscopy at this juncture, I wouldn't call it screening anymore. I would throw out that time interval,
mm,
and disregard it, and you would need to go for that scope. But let's say you remain completely well, then you may want to. It's perfectly fine to stick to that interval. Do you know what I mean?
mm. Yes. So the symptoms that might appear between the next colonoscopy, it's like what he said, piles, bloatedness. Are there
Yeah.
more of such symptoms
Well, I
that we
think
should take
the
note of?
most worrying symptom
Mm,
is what we call change in the bowel habit. And that might be like a diarrhea or constipation, or
mm,
change in the consistency of your stool. But of course, every now and then, we might eat something wrong, or we might pick up a
mm,
bug. But these sorts of changes, if they are persistent for, say, more than 3 or 4 weeks, you know, then I'll be worried something is wrong, and it's not just a
mm,
bug that you picked up, or it's
mm,
because you ate something, that wasn't so clean. If you develop rectal bleeding, well, then that can be worrying. If you start to have abdominal discomfort, cramps, or you feel gassy, or you feel a bit of pain, that might be worrying. If I mentioned before, the feeling of unable to completely evacuate when you go to the toilet, that's also significant. Some
mm,
people, they become anemic when they have cancer, and sometimes it's a very subtle feeling of just fatigue or vague weakness from the anemia,
mm,
you know.
mm.
But the long and short of it is that most of these symptoms are actually not early signs,
Oh,
okay? Because
oh,
unfortunately, I have to say that I don't think there are early signs. You know,
wow.
if you have, generally speaking, if you have like a small cancer, a early one, most of the time, it would not have been picked up because you had a symptom. It's likely to have been picked up more because you went for a screening, meaning you were feeling completely well and you thought, okay, I've reached a certain age, I think I should go for a check, Yeah. So if you start to have symptoms, chances are it's not that early, unfortunately. Statistically speaking, of course, there are odd cases that we are still fortunate that it is still very early.
And do you think that 5 years is considered too long? What if, yeah, like you said, within the 5 years, it suddenly popped up, but it's too late
Okay.
already?
Now, actually, the recommended interval by the Ministry of Health, and this is for what we call normal risk individuals, right? And you don't have a family history, and you have reached the age of 50, is actually doing your first colonoscopy at age of 50, and then every 10 years. Now,
Okay.
now that's assuming that every time you've done your colonoscopy, you had no polyps and the bowel preparation was good, so that the doctor doing it is fairly confident that he got a good look, right? If you had a colonoscopy and found that you had polyps that needed to be treated, or the bowel prep wasn't that great, then more prudently, you probably should reduce that interval, something like sometimes 5 years, sometimes 3, depending on case by case. Sometimes it's what is the biopsy report like from the polyps.
Okay, thank you, Dr. Ng. I hope that answers your question, Andrew. I think it's a good thing you shorten it to 5 years for your screening. So we have another question from an anonymous attendee. So the person says that she is a patient with, okay, I don't know how to pronounce this. I'm gonna butcher it. Peutz-Jeghers syndrome.
Yeah.
Okay, and the person has multiple polyps from his esophagus until his rectum, and he wants to advise on it.
Yeah, I'm sure that if you know your diagnosis, you would be already kind of seeing, or you're on a regular follow-up with a surgeon or a gastroenterologist to do regular screening. But this is actually a condition where you might develop multiple polyps in anywhere in the gastrointestinal tract, not just the colon and rectum. And these polyps have some risk of becoming cancerous. It is true. So you would have to go for very regular screening. Yeah, and unfortunately, usually the polyps might be so numerous that unless a cancer actually develops, right, it may not be practical to aim for complete eradication or removal of every single polyp, all the time, but rather that more like you will, remove very large ones and suspicious ones. If let's say you had a lot, it may not be practical to remove every single one, but you would want to remove the very large ones that you might be worried about. And I'm sure your doctor would have a very regular schedule for you to come back, but you should be very careful and not miss any of the sessions.
Okay, thank you, Dr. Ng. I hope that answers your question, anonymous attendee. The next question we have is from Gilbert. So Gilbert wants to ask you about the article that you mentioned about bowel preparation. So is it the mechanical and oral antibiotic bowel preparation for elective colectomy? So he brackets mobile trial.
Yeah, I am referring to that.
Uh,
So that particular oral antibiotic is not widely available in Singapore. But I am referring to that. So this applies to surgery, colorectal operations. But the commonest reason why people take bowel prep is actually for colonoscopy. Okay, not surgery itself, right? So for colonoscopy, there's no thinking that you need to take that antibiotic, because we just want a mechanical cleansing, which is just the prep itself, so that it's clean. We get a good view when we do a colonoscopy, and we try to remove hopefully any sign of early polyps and things like that.
Okay. So I hope that answers your question, Gilbert. And also, actually, we are drawing closer to 7:30 already. Before we end, I actually want to ask you one question, and that is, what is one take-home message you would like your audience to walk away with in regards to colorectal cancer?
I think I think in case some people have missed some of our earlier discussion, the take-home message, the main thing that I hope people get is in the understanding that how common colorectal cancer is in Singapore. Literally, out of 20 people one might get it, which is pretty alarming when you sit down and think about it. So, and actually, cancer of this type is preventable when you catch it early. If you catch it at a precancerous stage when you do colonoscopy, you've basically nipped it in the bud. If you catch it when it's an early cancer, you go for a treatment, and it's highly curative also. But the early cancers, like I mentioned before, seldom have much symptoms. So the other take-home message is that screening is very important.
So everyone above the age of 50 should really start going for screenings, male or female. Okay.
Yes, and I would also add that if you have a family history, sometimes we would recommend an earlier age to start screening.
Okay, thank you, Dr. Ng. Actually, I have one more personal question for you, and that is, what is the most memorable colorectal cancer case that you have ever experienced in your career?
Well, I think I can think of a recent case where actually a senior colleague of mine, he's another colorectal surgeon. He himself had just done a colonoscopy for his younger sister, and he phoned me and he said that he found a cancer in his younger sister. And he told me he wanted my opinion on it, and that he wanted, in the end, he wanted me to perform the surgery for the younger sister. Now, while that was personally impactful because I felt it was my privilege to be of service to my senior colleague, who himself is another colorectal surgeon. But more impactful was actually this younger sister of his was kind of almost the same age as me. And I kind of identified with her a lot. And, and it also reminded me of all the statistics. Sometimes when I talk about it, maybe sometimes I even don't internalize it quite so much, but suddenly it's a good friend's sister, and she's like similar age, and then it just reminded me that I have to take everything very seriously.
Yes.
Yeah. But that case, I guess, was impactful to me for several reasons. Yeah.
I think it's very easy to get jaded because you are in the field and you experience it every day. And I think the take-home message is, don't take your health for granted. You should really go for screening all the time. So thank you, Dr. Ng, for sharing your story. And I think it's actually 7:30 now. So I think it's a wrap for our Q&A section and as well as our webinar. So I'm sure all of us have walked away new insights about colorectal cancer and the importance of screening. So if you would like to engage the services of Dr. Ng, you may do so via his Clinic 1 Surgical Clinic and Surgery or via our website, www.drextentis.com. So thank you all again for taking part in today's webinar. You guys have been lovely audience. As I mentioned at the start of the webinar, this session is recorded and you will be able to find the recording on our Facebook page, Dr. Extentis. Stay tuned for the post-webinar email where you will also receive the link to the recording and also more reading materials written by Dr. Ng on the topic of colorectal cancer. And on behalf of everyone at Dr. Extentis, I want to thank our panelist, Dr. Ng. It's been our pleasure to have you this evening. Thank you, Dr. Ng.
Thank you very much.
So to our audience, if you have any more questions about colorectal cancer or about anything at all, you can always go down to our website, www.drextentis.com to drop your questions there. Our team of doctors will definitely get to it. So with that, I wish all of you a pleasant evening. Stay safe and goodbye. Go for screening. Check it out. Thank you, Dr. Ng.
Okay.
Thank you. Bye-bye, everybody.
Thank you. All right. Good night, everyone.
Bye-bye.
Bye.